Okay, this is Beth Lubenthal, and I am just finishing up the lecture for schizophrenia and other psychotic disorders, and it's just finishing up the nursing process. And we were just finished promoting adequate communication when we were in class. Just wanted to pass on that I did talk to Steve, and he plans on talking with his clinical group about some of the things that we discussed in class. So if you're in Steve's clinical group, look forward to that conversation. The next nursing intervention is promoting adherence with a medical regime. I just want to look at the word adherence and ask you to think about what is the difference between the word adherence and compliance, and why now the literature and modes and healthcare providers really are making a movement towards the word adherence versus compliance. Adherence suggests and encourages that the patient is a partner in the care and in his medical regime, and we want him to be a partner, and we want him to take responsibility, and want him to have a commitment to this process. The term compliance oftentimes, and non-compliance, oftentimes connote or can give the impression that we know what is best for the person, and if they don't follow what is best that we have put forth, then they are somehow incorrect, and they don't know what they're doing, and they are being non-compliant and choosing not to follow our directions, and of course then that is bad. Where the case in point might be that the patient feels that these medications are causing too severe of side effects, and they're choosing not to adhere to these medications and would like to talk to the doctor about not using these medications and possibly choosing some other things. So I think it puts forth a sort of a philosophy of how we want to approach the care with our patients when we use the word adherence versus compliance. Okay, so promoting adherence with the medical regime. Page 353 in your book, there is a two boxes there. One is important issues for the client with schizophrenia that I want you to look at and read, and the other one is your self-awareness. So take a look at that. But on page 353 also is where this intervention starts and starts to talk about it. And obviously your book says that it can be a very complex situation when we're trying to help individuals stay on a medication regime. There also is a box on the next page, on page 355, that talks about your interventions with clients with schizophrenia and how to increase medication adherence. So again, I want you to look at that as well. One of the big things that we need to look at is making sure that we're educating our client as much as possible, and that we are helping them understand the reasons for the medication, what is the illness about, what is the disease about. It's important that we simplify it any way that we can. Many hospitals and inpatient units, before a patient is discharged, will have the patient practice a medication adherence before they're discharged. So it's a type of self-administration. So instead of the nurse just going around to that person with schizophrenia who's going to be who will be discharged, say in a week or 3 days or so, they will be given instructions. They'll be given a med sheet with all of their medications, when their medications are, when they're supposed to take their medications, and then it will be their responsibility to come and approach the nurse for their own medications, instead of having the nurse seek the patient out. That's just one way of self-administration that we can help them with before they leave home. And then once the patient does approach the nurse for their medications, the nurse can sit down with them and say, okay, great, now what medications do you need? Tell me what your dose is, how many pills that is, and the patient can start getting in the habit of being responsible for that medications, figuring out those meds himself, knowing how many pills, reading dosages, that sort of thing. So that's just one thing, but I do want you to look at that purple box on page 355. The next intervention is promoting grooming, hygiene, and ADLs. And again, your book does a good job talking about that. Again, many times we take it for granted that everybody should know how to do that, but oftentimes people with disorganized thinking, hallucinations, or delusions may need to have some of these ADLs retaught to them, and retaught how to keep on a schedule, and maybe writing a schedule down. So we can look at things that might motivate the client and help them with their own motivation, but also to set clear expectations of what we would expect of them, but also what they should expect with themselves, kind of a baseline type of hygiene and grooming. We can also work on verbal coaching with the patient, not just telling them what to do, but encouraging a coaching relationship, a team approach, where we're helping them and looking at motivation and giving them positive feedback. There may also be times where we need to give them, especially on an inpatient unit, giving them gentle physical guidance, and that requires a lot of patience from the nurse and the healthcare providers. But to say, right now we need to start to brush our teeth. Let's think about the supplies that we need. Let's think about what are the steps in that, and then to gently encourage them with those ADLs. It might be that if they need to get into the shower, if they haven't had a shower for 2 or 3 weeks, or haven't washed their hair or that sort of thing, we might need to gently and maybe possibly help them with permission to help them step out of their clothing, get into the shower, again asking permission, can we help you wash your hair, and gather supplies for them, that sort of thing. The next intervention, promoting organized behavior. If the person is disorganized, they are going to need direction. For instance, if they don't know how to even make their bed, if they do not know the steps as far as how to come out to the day room to get their tray, to eat, that sort of thing, we might need to spend a lot of time with them, giving them directions. Okay, we need to make sure that as we're promoting this organized behavior, that we're very slow and calm in our manner, and not being impatient and not being dictatorial. Making sure that we give simple directions and simple steps. There is a clinical example, a good clinical example in your book that I want you to read related to this. We also might need to set limits. If a person is, again, maybe hoarding magazines in their room, or stuffing paper towels down their toilet, there might be limits that we need to set. Like, for example, you are only allowed to have 2 magazines in your room at a time, or we can't allow you to put paper towels down the toilet because it clogs the toilet. So we are, if you aren't able to follow that, we might need to lock your bathroom, or we might need to take the paper towels out of your room. So certain limits like that might need to be put in place. Promoting social skills, interactions, and activities. Remember that many of these individuals may deal with anxiety by staying by themselves, staying alone, being by themselves, isolating themselves, and to remember that it might be very anxiety-provoking for them to talk with other people, to go out in public, to ride the bus, etc., go grocery shopping. So we need to remember that there can be some anxiety in this situation, and then and be sensitive to that as we're helping them and teaching them, and remembering how difficult it might be. The basic therapeutic relationship is very important for us to practice in this relationship with them, and we're really looking for small increments of change here, and slowly working up to bigger changes. So it might be that they can only come out of their room and sit for 10 or 15 minutes and watch TV. That might be the initial goal. The next goal might be coming out of the room for 2 or 3 days. Then eventually, maybe attending 1 group a day with a staff person, and then, gradually increasing. That's what I'm talking about slow increments of change. The nurse can play a very important role here in modeling and role-playing with the patient. What is appropriate social skills? What are appropriate interactions? We can focus on situations that the patient may encounter. We can actually have them practice and do some role-playing, possibly before they're discharged, or if we're in an outpatient treatment center or partial hospitalization. A lot of the groups focus on these social skills. The patient may need practice or may need teaching about how do you introduce yourself to somebody and start a conversation. How do you ask for directions? Say you're in an office building and you need to find your doctor's office. How do you go about asking directions? And then to role play with them or role model with them. And also, what are meaningful activities for the patient? Maybe some brainstorming. What would be meaningful to him? What activities could he get involved in? What interests do we have? We need to think about activities that are going to build confidence in him in relating to other people, but also doing, productive work. It might be, if they're on an inpatient unit, that maybe there are unit jobs that the patient might do, like making coffee, like straightening up the day room, something like that, and then gradually increase those, and then to work on those as, with a counselor on an outpatient basis. The next intervention, promoting congruent emotional responses. We need to remember that our clients, our patients, have feelings, but many times these are difficult to communicate. And to remember that they have ambivalence, and this can definitely, contribute to that incongruent emotional response. But we can help them identify conflicting feelings or thoughts. If we notice that a person has a very flat affect, and maybe we are talking about the death of his brother, we could, after trust is built and we're in the working phase of the relationship, we could definitely, bring those out and see if that might be something that he wants to do, talk about these feelings or talk about thoughts. On page 357, there is an example of that. And so I want you to take a look at that, and also read the area that talks about ambivalence with that as well. The next intervention, promoting family understanding and involvement. One of the big things here that we want to do is refer family members to resources that are out in the community. There are many good resources. For example, many mental health clinics, or for example, Vera French Community Mental Health Center, Robert Young Mental Health Center across the river, have many psychoeducational groups for patients, but also for family members to come together to benefit from other family members' experiences, learning from shared experiences, that sort of thing. But that there also would be, say, a nurse or another healthcare provider that may be leading this group and providing education, providing support for these individuals. There's also the National Alliance on Mental Illness, or NAMI. Maybe many of you have heard about that. NAMI is almost in every community in the United States, but they offer education, support, political activities for family members and for patients to get involved in. But this is a huge group, a national group, but that provides individual support of family members, for patients, for clients, groups, social activities, support. So those are two very good groups. Many hospitals, or inpatient hospitals, Genesis doesn't have this, but often we'll have a family night where, say, every Wednesday night they will have a family group where patients don't come to it, but all family members can come and talk about issues that they might have. Of course, there'll be a nurse or somebody leading the group. Will be able to answer questions, provide education. Promoting community contacts kind of goes along with that family understanding and involvement. But again, we want to try to get the patient to the highest level of functioning possible, so remember that. So once we want to, before they're discharged, helping them find contacts so that once they are discharged, they can work on this highest level of functioning. So some of those community contacts might be, like I said, NAMI, but it also might be a partial hospitalization program, an outpatient program, making sure that they have not only a physician or somebody to prescribe meds for them, but also somebody who is a person who may be available for counseling and for support. Many times community
depending on the community, we'll offer halfway houses, or we'll offer supervised living situations. Vera French has supervised housing where they will have apartments where individuals can live in, but there'll be case managers or support people who will come and check on those individuals every day, spend some time with them. Vera French also has a community program or community support program called Frontier, where it's open every single day. Patients can drop in, get their medications, but they can also drop in and play pool, have coffee, visit with people. They can have a free breakfast and a free lunch if they are willing to do a few little chores around the facility. So making sure that we are aware of, what community resources we have in your own individual community, and then making sure the patient knows that and referring them to that. Patients can also do a lot of, if they're unable to work for disability reasons, volunteering that they can do, but also if can't, hopefully they would be able to have a job, get back to work, or maybe it's just working part-time. Okay, so managing hallucinations and delusions, page 356 in your book. There is a purple box on page 356 that talks about helping a client manage hallucinations. I want you to take a look at that. And then on page 357, a purple box that talks about helping a client manage delusions. So I want you to make sure that you take a good look at that, both of those. Read very carefully. Delusions. We talked a little bit about what are some of these principles. One of the principles that we want to always follow is not to argue with the delusions, okay? Not to try to convince them that they're wrong, okay? We can shed doubt, and again, we talked about that. That's hard for me to understand how that might happen, but, and then go on and talk about the underlying feeling, okay? And and another principle to think about also is bringing the patient back to reality, not necessarily arguing and saying your delusion is wrong, but bringing them back to reality instead of, having them go on and on about their delusion. And might be, okay, well, we've talked about that for a while. Now, how about if we go ahead and we can talk about your discharge that's coming up soon, or how are you doing with your volunteer work? Bringing them back to reality. Okay, sometimes it's very difficult to get patients off of their delusion and talking about the here and now and reality situations. So sometimes what has happened, or might be an intervention in an individualized care plan, would be, let's set a 10-minute or 15-minute time limit for how long the patient can talk about the delusion. And we tell the patient that ahead of time, and then when the 15 minutes is up, then we steer them back to a here and now topic or a reality topic. So for instance, if I was starting a one-to-one with a patient, I might say he might be going on and on about his delusion. It's very difficult to get him to talk about, maybe some other important reality issues. I might say, well, you know what, we have about 15 minutes, or 10 minutes, if you want to talk about, whatever it is that he wants to talk about, maybe his, some hyper-religiosity topics or that kind of stuff. We may let them talk about that for 10 minutes, but then at 10 minutes we would gently tell him, okay, the time is up, and now we're going to get back to talking about these issues. Okay, now that would be an intervention that would possibly put into place after a lot of trust is built, and you're in the working phase of the relationship. Okay, and hallucinations, again, to acknowledge that you know that the patient is having that hallucination. You don't have to agree with it, and you might even say, I don't see the bugs that are on the wall, but I know that might be scary for you. I do want to let you know that there's a nurse here 24 hours a day. We are doing checks on you frequently. You are in a safe place, and we're not going to let any danger, come to you. Okay, so letting them know about their safety, and you understand, or trying to understand what their feelings are. But it is also okay to say, I don't see those bugs, or I don't see those shadows on the wall, but I understand that you do. Okay. All right, the next intervention here is managing the agitated patient. I want you to look at pages 761 through 767. This talks more, it's more in the chapter on violence, but the therapeutic relationship is very, very important. Okay, can't say enough about how that is going to help you manage the patients on the unit or other patients. You know, sometimes we need to think about, when we have a therapeutic relation, it will be easier for us to determine, why is this person agitated? Are they having hallucinations? Are they having delusions? Are they angry at just coming out of a hearing? And they've been committed? Are they angry at their parents for filing commitment papers? There's one situation I remember working with a young man, and I was working over the weekend, like 3 days in a row. He wasn't my primary patient, but I had him Friday, Saturday, Sunday, and over that course of those 3 days, I had developed a good deal of trust with him, had some really good one-to-ones with him, was working with him. A Monday morning came. I also worked Monday morning, but his primary nurse was back on Monday, and so she took him, and she really this was the first time that she met him, but for some reason, I forget exactly what it was, if he just got off the phone with a family member, but he started becoming very, very agitated, and was starting to escalate, and becoming more of a risk for violence. And his nurse that was assigned to him on that Monday morning, again, didn't have a huge rapport built with him yet, but she was trying to redirect him and help him with yelling and that sort of thing. She was not making much progress, but so then I just went up and said, hey, John, what's going on here? It sounds like you're really upset. How about if we go down to the end of the hallway, sit down, let's take, talk about what happened on the phone. And he, kind of looked at me, and I'm sure he was thinking about, not consciously, but it came to, I know this person from the past 3 days. We've sat down and we've talked many times before. Yeah, I can go down and sit with her and talk with her. And so we did that, and his agitation and anger started to decrease, and he was able to go back into his room, rest, and the agitation was okay. After that, I went back into the nurse's station, and the nurse was like, "Wow, Beth, what happened, or what did you do that he calmed down right away when you were talking with him and stuff?" And at the time, I was like, I don't know what I really did. I just talked with him. But on further reflection, I knew it was because those 3 days I took the time, sat down with him, talked with him. And built that relationship and built that trust. So you can see that trust, you don't know what's going to be happening in the future, but you know that it goes a long ways when we take that time with that therapeutic relationship. Milieu management is very important as well, and on page 763 talks about that. Let me just turn to it in my book here. So intervention strategies, and again, there's a purple intervention strategy box, guidelines for working with the angry client. It has the nursing interventions and also the rationale. So I want you to take a good look at that and read that very carefully. Okay. And one other thing that I wanted to point out to you is on page 767 in that chapter also talks about verbal interventions and positional strategies when working with a client who might be agitated. One of the things that I always try to do is put my hands down at my side when I'm talking with somebody, kind of stand at an angle to them, and where they feel like they can have an escape route if they are feeling paranoid or agitated, and that I'm not standing right in front of the door, but I'm turning towards the side so that they can move away freely, compared to where the door is. But I want you to read that as well. Okay. Pharmacological management with an agitated patient. It may be that the patient does need to have some medication. Many times for a person who is starting to escalate, having a lot of agitation, yelling and screaming, we will offer them an antipsychotic such as Haldol, and many times we combine that with a benzodiazepine like Ativan. Okay, so Haldol and Ativan. And many times patients will refuse the Haldol and just want to take the Ativan, and that's okay too. But many times offering them a PRN to calm them down, have muscle relaxation, allow them time to just kind of take a break and get their thoughts
back into a more stabilized thought process is important. And usually it's better to offer that PRN when we start to see signs of agitation, not when they're in a full-blown agitation scenario. So that requires a lot of consistent and astute, assessment skills. All right, the next intervention, and I guess I'm not on the slide now, is preventing relapse and looking at relapse triggers. We want to make sure that the patient, as I mentioned before, is taking their medications, trying to get them into a routine. We definitely can work on that prior to discharge. We want to talk with them about how important it is to be in a low stress environment and to be able to recognize when things are getting stressful in our life and teaching them about that. And that's kind of those recognizing those relapse triggers. Everyone relapse triggers might be different. One might be every time I go visit my mother, she is gets me agitated and pushes my buttons, and that might be a trigger for someone. Newer situations, starting a new job, starting a class, going to a new group might be a stressful situation. That might be a trigger for someone. Any situation that interferes with a person's routine, such as they've come down with the flu or they're traveling out of town for the weekend. Okay, those again might be triggers for them to get off their routine, get off their medications. Okay, anytime they might be in a very hypercritical situation or a very non-supportive situation might be triggers for them. So it's important for nurses to help them think about these triggers, prior to discharge, or think about these triggers, if we're on an outpatient basis, help them think about those and then put in what can I do when I know that I'm going to have to visit my mom. Or maybe we can meet, instead of meeting at her house, we meet at the coffee shop in a neutral situation. So there's a lot of different strategies that can go along when we're talking about relapse and triggers. It's important that we look for early interventions when we start to see signs and symptoms of stress, to get family and support systems in place. We don't want them to have to relapse and come back into the hospital if possible. Okay. Evaluations, which is the next slide. Evaluate the outcomes that we talked about earlier. So, are they able to think logically and be goal-directed in their conversation? Are they back to reality? Are they oriented ×3? Are they not having hallucinations anymore, not having delusions anymore? That's evaluating those outcomes. Are they in a safe environment, and are they safe themselves? Okay, and again, trying to get them to function at the highest possible level. Maybe they aren't at the highest possible level at discharge, but we're putting things in place so that they can work on that when they are discharged, and then evaluating that. Okay, so that is all I have for the nursing process. We are going to be having our test on Monday. So I'm going to post this on Blackboard. And if you have any questions or concerns, please email me or stop by my office. Thank you very much. Bye.